Alright guys, welcome back. So last respiratory video, we finished up the obstructive lung diseases, and so far respiratory has been a very successful in-depth review of how the lungs work physiologically, how atelectasis affects you, what the VQ mismatch is all about, a bunch of stuff like that, right? We talked about the flow volume loops. There's all kinds of stuff in respiratory, and it's second only to cardiovascular. Cardiovascular is full of many pathophysiological mechanisms and many diseases and heart conditions and graphs of all kinds, and of course even heart sounds, right? Similarly, the lung is also full of sounds and graphs and stuff like that, but it's less severe than it is in cardiovascular. And then the pathophysiology of how blood pumps through the heart and how the valves work and how the heart develops. You have stuff here too in terms of intrapleural pressure, intraalveolar pressure. We talked about all of that in those graphs in the earlier respiratory videos within the physiology section. So last video, once we were done with obstructive, now we're looking at restrictive lung diseases, and there's a whole list. There are far more restrictive lung diseases than there are obstructive. So as far as obstructive was concerned, in the last video, it was basically just COPD type stuff, right? So chronic bronchitis, emphysema. You get a lot of questions on that. It'll definitely be on your step one. Asthma, many different types of asthma. It's not just one thing. And we talked about asthma in a very in-depth way where we understood the pathogenesis of asthma in terms of initial exposure, repeat exposure, and all the cell types that are involved in actually causing the reaction. And then of course the next page, right, bronchiectasis, the smaller topic but more so significant for cystic fibrosis, which in itself is a very big topic. So those things go hand in hand. Now, restrictive lung diseases, personally, I felt like the best way to really get a good grasp on them is to do a lot of practice questions. Once you look at the questions, you get to see how it presents in all the different scenarios and what's different between each one of these, and then you start getting a good hand of what's happening. So restricted lung expansion. So restricted lung expansion causes a decrease in lung volumes, right? That's what restrictive lung disease is. Your lungs cannot expand. So that means you can't fill them up as much as you used to before. So you have a decrease in FVC and obviously the total lung capacity, right? TLC has decreased. Unlike obstructive lung disease, here you have an increase in FEV1 to FVC ratio, and that was a big deal because here in obstructive lung diseases you have a severe decrease in FEV1, right? An overall decrease in FEV1 to FVC ratio, which they say is even a hallmark. But keep in mind from that last video, we said that another thing that you could look at for obstructive lung diseases was the RV to TLC ratio, residual volume, because you have a lot of air trapping, so you have more residual volume than you would normally have, right? So in restrictive lung diseases, increased FEV1 to FVC ratio, a severe decrease in total lung capacity. Right here I wrote FEV1 and FVC both decreased, but the ratio is typically increased because there was a larger decrease in the FVC due to the airway widening relative to lung volumes, right? So that's an important one to understand. You can get silly questions on that kind of stuff. Now there's two general types. There's the one with poor breathing mechanics, right? So restricted lung diseases where you have poor breathing mechanics, either due to poor muscular effort, such as in polio, myasthenia gravis, or GB syndrome. Or you could have poor structural apparatus, right? So skeletal issue with the rib cage or the spine. And here they have scoliosis or morbid obesity, which is definitely a big issue. We're going to see more relevant obesity stuff for lung issues, especially when we get to obstructive sleep apnea. And here what happens is that you're going to have a normal DLCO. The diffusion capacity for carbon monoxide is going to be normal, and that's directly related to the alveoli. The alveoli are going to be normally functional. The second type are your interstitial lung diseases, where you can see there's a whole list of completely different things. You've probably seen some of them before, like we saw Wegener when we were in cardiovascular, right? Granulomatous polyangiitis, that was in cardiovascular. I don't think we've seen primary Langerhans cell histiocytosis. I think this was in hem-onc. Drug toxicity, of course, when we did the oncology treatments, a lot of them had lung toxicity, and amiodarone from cardiovascular had lung toxicity. That's about it from here. Oh, and sarcoidosis, but that was in musculoskeletal. That's another one. That's an interstitial lung disease. Right. Then the ones that are new to respiratory itself are your pneumoconioses, which I'm going to try to do. I think that, yeah, that's going to have its own video. That's going to be the next video after this one, where I'm going to try to get all of them into your mind perfectly without any confusion. You should be able to figure out exactly what's wrong and what's expected in a patient based off of the exposure they had, whether it be coal, silicosis, asbestosis, whatever it is. Idiopathic pulmonary fibrosis, one of their all-time favorites, right? Anything idiopathic makes for a great question because you, as a student, as a test taker, you're not going to see a reason to pick something, right? It's idiopathic. They don't need to give you a reason, and you're not going to see a reason. So you just have to understand from the information given and the presentation given that this must be pulmonary fibrosis. Why does he or she have pulmonary fibrosis? No idea. Right? So they go on to tell you that it's possibly due to repeated cycles of lung injury and wound healing with increased collagen deposition. You would note a honeycomb lung appearance, which is what they're describing here. The traction bronchiectasis as well. Now, you're not necessarily going to understand the difference between all of that, but basically all of this is honeycomb appearance. The traction that they're talking about, traction bronchiectasis, is kind of this long black line you're seeing here, right? It's just like the bronchiectasis was, right? This is bronchiectasis here. This image below is bronchiectasis. So you can see you have that long line right here that's numbered 2 from Amboss's image, where they kind of, one of the reasons I'm doing respiratory again anyway is because of Amboss. They did an amazing job with the highlighted and color-coded x-rays and CTs and all that. So here you can see number 2, the tram track line of parallel linear opacities, right? That kind of stuff is a sign of bronchiectasis. That image here is only bronchiectasis, but this image right here below, you're seeing bronchiectasis, right? 1 case of it, 2, 3, and then this right here, 4 cases of it. And then the rest of it is just a honeycomb appearance from all that extra fibrosis and collagen deposition. Usually it's going to be a patient who just had some kind of lung insult for whatever reason, and then eventually started getting pulmonary fibrosis. Goodpasture syndrome we've seen before, right? There's the mnemonic, too good to be true. 2 plus 2 is 4. So Goodpasture syndrome is a type 2 hypersensitivity, I believe, against the basal membrane stuff. So when we get to Goodpasture syndrome, we'll talk more about it. Let me just check real quick. Goodpasture, yeah, it comes up later on. But slightly confused right now if it was type 2 or type 4 because I remember the mnemonic is supposed to add up. But either way, when we get there, we'll see it. This is a very significant one as well. You usually have patients who have like coughing up blood and whatnot. And a very important thing for respiratory questions when you get them is that regardless of how they present, right, always pay attention to the fact whether or not they have a fever. Because if they don't have a fever, then you could pick one of these things. But if they do have a fever, it could just be pneumonia or some other microbiology related condition. The last thing on this page, and they talk about it separately here, is your hypersensitivity pneumonitis. Right? This is also a very clever thing for test writers. They love testing you on this because the question is really based off of whether or not you remember hypersensitivity pneumonitis. This is a mixed type 3 and type 4 hypersensitivity reaction to environmental antigens. Causes dyspnea, cough, chest tightness, and headache, often seen in farmers and those exposed to birds. Right? So people who have birds can also go through this. Reversible in the early stages if the stimulus is avoided. Right? Now, hypersensitivity pneumonitis, I also have a bird. I have a really big African gray parrot. And he always has this like feather dust coming off everywhere, and I always have to like wipe it off of places. And I try not to be around him when he's really dusty, and I give him regular showers and whatnot. But just doing that, I always just think about the whole concept of hypersensitivity pneumonitis, and it became very real to me, and I would just remember it. So this image here is showing you some of what occurs in hypersensitivity pneumonitis, and down here are some notes on it, so let's take a look. Unlike asthma, which is going to be your other differential option, the other thing that the question is going to try to give you, Your question is going to try to confuse you between asthma and hypersensitivity pneumonitis. Unlike asthma, hypersensitivity pneumonitis shows that inflammation is centered in the alveoli rather than the bronchi, right? With asthma, the problem is in the bronchi. With hypersensitivity pneumonitis, the issue is in the alveolar level. You note an IgG antibody type 3 as well as CD8 positive type 4 hypersensitivity, both simultaneously. Your patient might present with shortness of breath, cough, and more 4 to 6 hours after exposure. In farmers' lungs, exposure is to thermophilic actinomyces or aspergillus fungi in moldy hay or compost. Bird exposure is bird breeder's lung exposed to avian proteins in dry aerosolized bird droppings. Right, and this is not going to be psittacosis. Psittacosis was also something we talked about earlier. This is not going to be psittacosis where you have true bacterial pneumonia. It's not going to be that. It's just avian proteins that are causing type 3 and type 4 mixed hypersensitivity. To the left, this image right here, histological slide, is pulmonary fibrosis due to amiodarone toxicity. Note the fine nodular pattern that is typical of most interstitial lung diseases. So this image, although it's directly showing you amiodarone toxicity, hypersensitivity pneumonitis also seems very similar to this. All right. And what happens oftentimes with especially NBME is that they'll use the same image for multiple questions. And if you've done a lot of NBMEs or if you looked at a lot of NBME questions over time, you'll notice that the same image shows up in a couple of them, but the question is a whole different question. And even the answer choice is a whole different answer choice. They even keep the same answer choice they had in the last question, just in case you're trying to get it right by remembering. But it's a whole different answer choice. So just be careful with that. All right. So now on the next page, I just have a bunch of practice questions, right? And the concept of these questions is to truly see how the patient presents, what's happening to the patient, and why the answer is what it was. Okay. And based off of that, you should be able to understand the whole concept as a whole, as a circle of any other type of question you might get regarding the same thing. All right, so let's get started. The first one, 56-year-old male smoker presents to your office complaining of a chronic cough. He initially had a morning cough productive of minimal sputum, but now the cough occurs throughout the day with large amounts of yellow sputum. He has been hospitalized several times in the past for respiratory infections requiring parenteral antibiotics. He has smoked cigarettes for the past 30 years despite multiple attempts to quit. Today, his oxygen saturation is low, 90%, at rest, and decreases to 84% when he tries any kind of exertion. What additional finding is most likely in this patient? So no matter what, the basic information that's been given to us is the fact that his oxygen saturation is low. And when your oxygen saturation is low and you look at your answer choices and you see increased erythropoietin production, you know that has to be true, no matter what. Even if the other answer choices look like they might be true for this patient, you want to pick the one that's 100% true, right? You know that any patient who's going through what this patient is going through, where his oxygen saturation is low for whatever reason, even if you couldn't come up with a diagnosis, you know he's going to have elevated erythropoietin production. This patient, the 56-year-old smoker with the history of all this parenteral antibiotic use for respiratory infections, he has COPD. He has COPD. Secondary to long-standing cigarette smoking. COPD can be due to bronchial asthma, chronic bronchitis, and/or emphysema. Chronic bronchitis causes hypoxia by decreasing the diameter of conducting airways, preventing adequate airflow, and emphysema causes hypoxia by dilating the alveolar air spaces so that there is insufficient contact between the air spaces and the deoxygenated blood, and you can't have gas exchange. Smoking can also independently cause hypoxia by increasing the concentration of carboxyhemoglobin in the blood. Hypoxia is sensed by cells in the renal cortex that synthesize and release EPO in response to for erythrocyte production. This secondary polycythemia is an expected finding in diseases or conditions that cause any amount of hypoxemia. Right? So that's all this question was talking about. They wanted to kind of connect it to EPO and renal function. Right? You're connecting COPD to renal function. Very classic way of testing. Step 1 loves that kind of stuff. Next question, a 52-year-old man is being evaluated for persistent, non-productive cough and exertional dyspnea that has progressed over the past year. Lately, he has had difficulty accomplishing normal daily activities. He has no significant past medical history, nor does he take any medications. He does not smoke or drink. Spirometry shows an FVC that is 40% of the predicted value, and his FEV1 FVC ratio is 87%. A CT-guided lung biopsy is performed, and histopathology shows dense fibrosis, fibroblast proliferation, and cyst formation, which are prominent in the subpleural regions. What is the most likely diagnosis? So this is why UWorld is very different from NBME, right? This question gave too much. They gave so much that they literally spelled out what was wrong with the patient, especially when they started talking about the CT-guided lung biopsy, right? With the fibrosis, obviously, like that's part of the answer right there. They gave it away. The answer was idiopathic pulmonary fibrosis. You know for sure he has pulmonary fibrosis because you have dense fibrosis, fibroblast proliferation, you're making some cysts. All of that was a giveaway for idiopathic pulmonary fibrosis, right? Non-productive cough, exertional dyspnea. His FVC is 40%. His FVC is lower than it should be, right? So you know at that moment you're picking something restrictive as an answer choice. He is presenting with a restricted profile on pulmonary function testing, and histopathology suggests IPF. IPF has findings called usual interstitial pneumonia and shows patchy involvement with dense fibrosis, right? This was an answer choice in NBME. There was an NBME question where they had this answer choice usual interstitial pneumonia, which is such a weird thing, right? What do you mean by usual? Right, so usual interstitial pneumonia is the same thing as IPF, idiopathic pulmonary fibrosis. The cystic spaces from the honeycombing and the findings are predominantly in the subpleural and paraseptal spaces, which is just extra anatomical information right there. All right, so not so bad. Now we have a slightly younger patient, 38. A 38-year-old man comes to the office with reports of dyspnea on exertion and decreased exercise tolerance. His medical history is unremarkable, and he has never smoked. He has gained almost 100 pounds over the past 4 years since leaving the military due to sedentary lifestyle. He currently weighs 297 pounds and has a BMI of 41, so that's definitely, by definition, morbid obesity. Nothing you can do about that. Nothing to argue that, right? It's definitely morbid obesity. His respiratory rate is 22 per minute, which is slow, and pulse oximetry is 93% on room air at rest, which is slightly low. Pulse oximetry, oxygen should just be 100%, or 99 at worst. They go on to tell you that the lungs are clear in auscultation bilaterally. What pulmonary function testing is most likely to be seen on this patient? So he has morbid obesity, and that classifies as this first group of restricted lung diseases, right? Poor breathing mechanics because of poor structural apparatus, right? Morbid obesity. So he's going to have a restricted lung profile. And you look at the answer choices, and they had a bunch of up and down arrows for this question, which is always so intimidating, right? So it was like a graph, and it had FEV1, FVC, TLC, ERV, and RV all listed, and then the different answer choices were up and down arrows for these measurements, right? And you have to know what you expect to see in restrictive lung diseases versus obstructive lung diseases. So in this restrictive lung disease, the first thing I always look for is that residual volume should be normal. Restrictive lung disease has nothing to do with residual volume. Obstructive lung disease is where the residual volume is much higher, because in obstructive lung diseases you have air trapping. You have air that's stuck inside your lungs. So you knock out any answer choices that don't have normal RV. Then you look for, of course, a decrease in TLC, right? TLC should decrease. Generally speaking, the concept is everything decreases when you have restrictive lung disease, but not residual volume. Be very careful with that. The three-letter things generally all decrease. So FEV1, FVC, TLC, and ERV all decrease, but residual volume should be normal. And then the rest of this explanation just goes on to tell you that morbid obesity is related to a reduction in ERV, which also causes FRC to be low. FEV1 and TLC reductions are modest and depend on the severity of obesity and body fat distribution, right? So morbid obesity, big deal over here for respiratory function, as well as, of course, this patient is going to have cardiovascular issues, renal issues. He's got a lot of things that's just not going to work out for him. Back to a really old patient again. So 63-year-old man comes to the emergency department with a 1-week history of progressively worsening shortness of breath and cough. The shortness of breath worsens when the patient lies flat in bed, and he needs to prop himself up with 3 pillows to sleep well at night. Right, so this is what we see in cardiovascular. We've seen questions where this kind of stuff was happening in cardiovascular. He has hypertension and type 2 diabetes and was treated 2 weeks ago for an MI. So his MI is still within the progression of an MI calendar, right? And he was treated with 2 stents placed in the LAD. His blood pressure is normal, pulse is okay. Well, actually 92. No, his pulse is 92, so it's pretty high. And respiratory rate 22, which is lower, on the lower end. His pulse oximetry is 89% of room air, which is also low. Chest auscultation reveals bilateral crackles at the lung bases and the third heart sound, S3, right? What factor is most likely accounting for his dyspnea? So all of this is a giveaway for what's like truly wrong with this patient. This same question could just become a cardiovascular question also. So you really need to understand the cardiovascular aspect of what's happening to this patient to understand what's happening to the lungs of this patient. Respiratory rate of 22 is, see, the reason you want to think it's low here because it's not really matching his pulse, right? His pulse is 92, so that's kind of beating pretty quickly. But if your heart is beating that quickly, you should also be gasping for air. Otherwise, one of the two things is not matching the other. There's a reason they gave both. Right? So your pulse should be around, like, of course, over 60. Your pulse should be definitely over 60, but below 92, not 92. It should be around like 60, 70. That's about it. Around 70. It should be around 70, and that's really it. Nothing more than that. His pulse is 92 as if he was running or something, but his respiratory rate is not matching that. Right? He's not breathing as quickly as his pulse is demanding him to. And nor is he getting the pulse oximetry. He's not getting enough oxygen for some reason. Something's not right. And you know what's not right. He has bilateral crackles at the lung bases because he has some level of heart failure, right? And fluid or blood is backing up from the left atrium into back to his lungs, and that's why he has this level of crackles. So you look at all your answer choices, and they ask what factor is most likely accounting for his dyspnea, right? Always pay attention to what the actual question is about. They just want to know why he has dyspnea. So the shortness of breath and cough, what's happening here? So the issue here is decreased lung compliance. That was the answer choice you would pick. His lungs are not going to be as compliant as our lungs, normal, healthy individuals' lungs. Dyspnea, bivascular crackles, and the presence of an S3 sound in a patient who had a recent MI suggests left heart failure. On top of that, his need for pillows to prop himself up also point at left heart failure. MI most commonly affects the left ventricle following rupture of an atherosclerotic plaque and the LAD, and they gave you that, the LAD information. If a large area of the myocardium is affected, left ventricular contractility significantly decreases, reducing left ventricular output. The resulting high end diastolic pressure impairs diastolic return of blood from the pulmonary veins. Right, so blood gets stuck in the pulmonary veins. The pulmonary veins are supposed to bring blood back into the left atrium, and then your left atrium will send it to the left ventricle, aorta, and so on. But blood is backing up. Increased hydrostatic pressure, which could have been another answer choice for this question. Increased hydrostatic pressure in the pulmonary circulation causes transudation of fluid from pulmonary capillaries into the lung interstitium. That's another thing that could have just been the answer choice, right? The answer choice could also have been increased transudation of fluid. Right? And transudation is a very important thing to understand as well. So increased hydrostatic pressure, increased transudation into the lung interstitium. The presence of fluid in the pulmonary interstitium causes distortion of the affected tissue, increasing resistance to movement, and that's just the decreased lung compliance, which was our answer choice. As a result, the negative pressure generated during normal inspiratory effort is not sufficient to adequately distend the lungs, resulting in poor gas exchange and shortness of breath. Right? You need to know this, that when you have inspiratory effort, you generate negative pressure to breathe in. This is the stuff we were talking about way earlier when we were in the first few pages of respiratory physiology, talking about the different pressures. Wrong chapter. Talking about the different pressures that we see on this graph right here. and how all of this works. As you see how during inspiration you have a negative intrapleural pressure, you initially have decreased alveolar pressure. This negative effort is what helps you breathe in, right? And then breathing out is a positive effort. Right, so very important to understand that little concept, because that kind of stuff they love just throwing in tacit choices, and then if you don't know the pressure differences involved with breathing in and breathing out and what the whole concept is all about in terms of physics, I guess, it can be very confusing and intimidating. So that's basically all there was to this patient. It was very clear he had heart failure, and it was very clear that he has a backup of fluid into his lungs, so there's going to be decreased lung compliance. Next question, 62-year-old man comes to the physician with shortness of breath. His symptoms have progressed over the last few months and have begun to limit his daily activities. He has no other medical issues and takes no medications. He drinks 3 to 4 alcoholic beverages a week and has a 50-pack year smoking history. Physical exam shows decreased breath sounds and scattered wheezes bilaterally. His chest x-ray is provided below and shows hyperinflated lungs and a flattened diaphragm. Did I get the chest x-ray? Oh, this one right here, right? So you could see in this chest x-ray, what I just described here. Let's keep it like this. You can see both things. Hyperinflated lungs and flattened diaphragm. What is the most likely increased in this patient, right? So this is what they generally refer to as your barrel lungs, kind of, right? So these are really big lungs, extremely big lungs, and the lungs are so big that your diaphragm has been flattened. Normally speaking, right, you would notice something like this for your diaphragm, right? You need this angle. This angle is very critical, right? This angle should be visible at all times. When you can't see that angle, you have to figure out why you don't see it. You either don't see it because it's full of fluid, right, which would be pleural effusion, or you don't see it because you have a flat diaphragm that got rid of the angle, right? 2 different case scenarios that could do this stuff. So either way, whatever the issue is, it's very clear here that this guy's lungs are way too big, right? So that is a giveaway for what's basically wrong with this guy. So what is most likely increase in this patient? Functional residual capacity, FRC. His x-ray is suggestive of air trapping, right, which is COPD. Right, there's air that's stuck inside the lungs. Why else would your lungs be so big? It's inflated with air. So it's suggestive of COPD, which encompasses a spectrum of diseases between chronic bronchitis, asthma, emphysema, all of that. Emphysema causes the destruction of interalveolar walls and diminished lung compliance, leading to air trapping in enlarged distal air spaces. This causes an increase in residual volume, FRC, and total lung volume. Chronic bronchitis causes airway inflammation and further exacerbates airflow limitation. Right? Very classic x-ray here that you can totally expect to see on your step 1, right? Because they definitely want to make sure you know about the flattened diaphragm. So that was COPD again in terms of an x-ray. This image here is a whole different concept of oxygen-induced hypercapnia in COPD. So this is more so related to real practice. Once you're actually practicing as a doctor, you start having to put this into effect on patients. You're gonna have to see something like this actually occur. So it's a very good question because it teaches you something very important. So let's take a look at what's happening with the 60-year-old patient. This image is related to this question right up here. A 60-year-old woman comes to the emergency department due to shortness of breath and productive cough. She has a 30-pack year smoking history. Her oxygen saturation is 88% on room air. On physical exam, she appears uncomfortable and uses her accessory respiratory muscles to breathe. Expiratory wheezes are heard throughout the lungs. She started on high-flow oxygen supplementation. Shortly after, she becomes increasingly lethargic and confused. Her clinical decline is most likely attributable to an increase in what parameter, right? Why is she having whatever's happening? Okay, so when you look at the question itself, right? First of all, it's really rare for them to use a female for such patients, but this is great that they did here because it can be anyone. So 60-year-old female, 30-pack year smoking history, oxygen saturation is low. So you can already see some correlation there, smoking and low oxygen saturation. Uncomfortable, using accessory respiratory muscles to breathe. That is sort of a giveaway for what might be going on with her. Expiratory wheezes are being heard. She's given high flow oxygen supplementation, and when they gave her the high flow oxygen supplementation because they thought that would help, right? Her oxygen saturation is low. She became lethargic and confused. So something definitely occurred as far as chemoreceptors and all that are involved with the brain, right? Because that's the only way oxygen would have any correlation with her lethargic and confused presentation. This clinical decline is something that you don't want to do one day. You never want to have a patient where you decided to do something with them and then they have clinical decline, right? No, you want to make sure your patients are getting better. So here the answer, an increase in what parameter? Physiologic dead space, 26%. 20% chose minute ventilation, 27% chose radical oxygen species production, and 17% chose pulmonary vascular resistance, while 8% chose renal bicarbonate reabsorption, right? So you can already tell that people were picking answer choices all over the place, right? No one truly knew what was happening to this patient. So what did happen? The image below, this one, was given with the explanation. Her clinical presentation is consistent with COPD. Very obviously, right? She has the dyspnea, the productive cough, the smoking history, the hypoxemia, the expiratory wheezing, use of accessory muscles to breathe correctly, right? Smoking history, they added that too. Supplemental oxygen may be warranted in patients with COPD who have significant hypoxemia, but administration of high oxygen concentrations can lead to increased CO2 retention. That, when you give someone oxygen and they have more CO2 retention, that's known as oxygen-induced hypercapnia, right? And too much CO2 is a form of acidosis, resulting in confusion and a depressed level of consciousness. And someone older, maybe if this patient was 70 or even 80, could actually die from something like that. The major cause is increased VQ mismatch, which could have been another answer choice. Instead of an increase in physiologic dead space, the answer could have been increased VQ mismatch. Same thing, right? Physiologic dead space increasing and you having a ventilation perfusion mismatch are very much the same thing. Hypoxia causes vasoconstriction of the pulmonary arterioles, which normally acts to shunt blood toward alveoli with the highest ventilation. Right? Remember that in the lungs, it's different from everywhere else. So if there's a certain part of your lungs that is not getting enough oxygen, you don't send more blood over there because the function of the lung is to put air into blood, right? So if there's a certain part of your lung that doesn't have air, you don't send blood there. That's different from your other organs where if there's, say, my left bicep isn't getting enough oxygen for some reason, there's going to be vasodilation and there's going to be more blood sent to my left bicep, right? That's just how everything else works. But functionally, because the lung's job is to bring air to blood, if there's no air, you don't send any blood. And that's kind of what they're describing here. So hypoxia causes vasoconstriction. You stop sending blood, right, of the pulmonary arterioles, which normally acts to shunt blood toward alveoli with more ventilation, more air. Redistribution of blood flow away from well-ventilated alveoli leads to an increase in physiologic dead space with a corresponding reduction in total alveolar ventilation. Minute ventilation, now the wrong answer choices. Minute ventilation would decrease in this patient, not increase. The question is asking what would increase. Minute ventilation would decrease because peripheral chemoreceptors in the carotid and aortic bodies sense the arterial PaO2 and are stimulated by hypoxemia. High flow oxygen reduces chemoreceptor stimulation, decreasing the respiratory rate and minute ventilation. Right? And this is something you just need to know. You have to study that. It's in cardiovascular near the end where they talk about the aortic and carotid body and how all of that affects your response to oxygen and CO2 levels. The answer choice of radical oxygen species was really just there to throw you off, and 27% of people picked it, right? Because high flow oxygen and radical oxygen species, someone can think it might be related, but it's totally not related at all. Radical oxygen species production can be increased in hyperoxia, leading to injury of the airways and lung parenchyma, but oxygen toxicity manifests with substernal heaviness, pleuritic chest pain, and cough within 24 hours after breathing pure oxygen. And she didn't have any of that. Had she presented, right, after the high flow oxygen, had she presented with any of these things, then you could pick radical oxygen species production. But I checked online later on and I realized that this would also require her to have normally functioning lungs to some level. Right? She is breathing normal air and she's still not getting all of it. Right? Her oxygen saturation is low and her lungs are not working that well to begin with. So this radical oxygen species production stuff won't really occur to her per se. But if a completely normal and healthy individual with fully functional lungs was to go ahead and take a shit ton of oxygen, hyperoxia, they can undergo radical oxygen species production. And even then, you have mechanisms to deal with it, right? That's what the whole G6PD thing is there for. You can deal with it yourself unless you have a deficiency of NADPH oxidase or G6PD deficiency, then, whole different thing. There was really no reason to pick this answer choice at all, right? The next one, pulmonary vascular resistance, right? That was another one that was 17% said pulmonary vascular resistance would increase. Pulmonary vascular resistance would actually decrease since oxygen administration will reduce the pulmonary vasoconstriction. Once the oxygen is there, you will send more blood there, right, to pick up the oxygen. So that was just another flaw in thinking, and there was no reason to pick that answer choice. The last one, bicarbonate reabsorption. Remember from acid-base physiology that any of that metabolic compensation takes time. Right? Bicarbonate reabsorption occurs slowly over 3 to 5 days in patients with hypercapnia and respiratory acidosis, which is what this patient has. With renal compensation of bicarbonate reabsorption to normalize the serum pH, she wouldn't have that within the same day, within the same few hours, in fact, right? So that just, although it is something that can occur, it wouldn't occur this quickly. Right? So that's a very important thing to watch out for. And then this graph goes ahead and summarizes everything that basically happened to our patient, going from baseline to after oxygen administration to the effects, right? Increased physiologic dead space, too much oxygen. So at baseline hypoxia, when there was no oxygen, she had pulmonary vasoconstriction, right? And this was a giveaway. That's why you would never pick as a choice pulmonary vascular resistance increased. That would not make sense. It is already increased because you knew she is hypoxic, right? Then you gave oxygen. Vasodilation diverts blood from the well-ventilated regions and brings it to the places that are now getting all this new oxygen administration. Since you have vasodilation and you're moving blood away from, parts of your lung that was getting blood, that's going to increase physiologic dead space. But it's not pathologic dead space because those spaces are still doing their job. They're just not getting enough blood now because you're sending all the blood to this brand new area of the lung that's getting excessive oxygen from the 100% oxygen that they were giving her. On the other red side, they're talking about the hemoglobin stuff. So high hemoglobin affinity for CO2, right, when you have hypoxia. Then you give the oxygen and you have a decreased hemoglobin affinity for CO2. This is the Haldane effect because you're going to go pick up the oxygen, right? We already talked about Haldane effect when we did the last video of physiology, right? Respiratory physiology. So when oxygen is actually finally there, Haldane effect kicks in, hemoglobin goes and picks up the oxygen, but then since you dropped all the CO2, you end up having more blood CO2. Right? The Haldane effect is directly to blame for, and it's a normal effect, of course it's going to occur, but directly to blame for the excessive blood CO2 causing the acidosis. This this excessive CO2 will affect your peripheral chemoreceptors. Right? They get stimulated, you have decreased chemoreceptor stimulation and decreased minute ventilation. Right? Really important to be able to understand this entire concept and the direct connection that some of these questions made between respiratory and cardiovascular and respiratory and renal. Very close relations between all of those organs. All right, one last question down here about a farmer, so you can probably already figure out what's wrong with him. 61-year-old farmer comes to the physician because of a 3-month history of progressively worsening cough and shortness of breath. He's had a 16.5-pound weight loss during this period. He smokes occasionally and does not drink alcohol. Physical exam shows clubbing of the fingers, which is directly a sign of hypoxia. And inspiratory crackles are heard in both lower lung fields. X-ray of the chest shows bilateral reticulonodular densities with interstitial fibrosis. Right? And that fibrosis, when they mention that in the question, is a giveaway for what the answer is. I already know right there at this exact point, I already know that this guy who is a farmer, and he could have also been just a bird owner, is most likely going to have hypersensitivity pneumonitis. But, of course, I'm going to keep reading. Histologic exam of a lung biopsy shows non-caseating granulomas. Which of the following is the most likely underlying mechanism of this patient's condition? Now, reading it, you see the correct answer was IgG-mediated immune complex deposition. And I wrote 25% got it right. The rest of the people guessed because the answer choices must have been everywhere. And there's a very high chance that some of these 25% who got this right also guessed and got this right. Hypersensitivity pneumonitis is characterized by a granulomatous interstitial pulmonary disease and is most commonly observed in patients with prolonged exposure to specific disease-precipitating antigens, such as fungal spores and thermophilic actinomyces found in moldy hay, because this guy's a farmer. This exposure induces a mixed type 3 and type 4 hypersensitivity reaction that manifests with IgG antibody-antigen complex deposition in the lung and subsequent granulomatous inflammation. But this granuloma business can really throw people off, right? You can see already on the next page, you can have a non-caseating granuloma in sarcoidosis. You get different granulomas as well in infection with pneumonia, right? Mycoplasma also. So you got to be very careful on what you pick, right? The weight loss, the smoking history, the clubbing, right? They gave you a bunch of stuff, but the real giveaway was the x-ray, right? The x-ray of the chest, and then the second real giveaway was the histologic exam. So basically what you would see is this. Well, this isn't an x-ray, but the x-ray will show you, I don't have an x-ray of that here, do I? Something similar to this. It will show you something similar to this. And the non-caseating granulomas, actually. Yeah, images A and B do the same job. It does the work for you. Images A and B here for sarcoidosis will be the same images you would also get for interstitial hypersensitivity pneumonitis. Pretty much, right? Same exact stuff. You're going to have your fibrosis. You're going to have your non-caseating granulomas. And remember, non-caseating granulomas, I always describe it in layman terms as a granuloma with a bunch of little black dots inside. Whereas a caseating one is cheesy, it's clear, it's all yellow. Just no little black dots inside. But a non-caseating one has a bunch of little yellow dots inside, black dots inside, or purple, whatever you want to call it, depending on the stain. And that's basically it for now. Alright, in the next video, now that we've done all these practice questions and seen how these things present, we're going to look at a couple other stuff, right? So we'll look at sarcoidosis, this one is a little topic. We'll mainly look at sarcoidosis, and then we'll go into pneumoconioses. And that'll be a big discussion about some of the high-yield stuff that pops up on tests. Inhalation sequelae of people who had to go through any kind of fire scenario and breathe in smoke. That's a whole separate discussion. That's really not a big discussion. We'll talk about that too right after sarcoidosis. Alright, so thanks a lot for joining, guys. We're going to finish up respiratory as soon as I can. Hopefully this weekend, actually, is what I'm hoping for. And then we'll continue on with NBME 21 over the week. Thank you very much for joining, and I'll catch you guys again later.